All right. Good morning, everybody, and welcome to the Beaker Holum of Greater Washington program, together with Ematai, an organization dedicated to addressing healthcare issues with Jewish wisdom. We are very fortunate to have had two previous programs with Rabbi Dr. Brody, who's joining us again today, on other topics of great interest. We spoke about legacy letters and halachic advance directives, and those were recorded and they're available on our YouTube channel. And also, certainly, any of you can request it if you can't find it. Happy to provide that with you. They were really wonderful programs, which is why we're so excited to welcome back Rabbi Dr. Brody this morning. I wanted to speak a word, some housekeeping business, before we get started with our program. Today is a busy day, I know for many of you. In the world of Beaker Holm of Greater Washington, it is as well. First of all, on a program note, following this program this morning, we are having an in-person boutique. So for those of you who are local, there will be a pre-Passover pop-up boutique with an amazing array of vendors, many of them local craftspeople. And it would be wonderful to see you there. It will be taking place at the Silver Spring Jewish Center. And it is happening just before this program's end 11, but it really gets started by 11:30 and it will be continuing until 4 p.m. So if you have an opportunity to get over there and check it out, that would be wonderful. You'll be supporting many businesses and a percentage of the proceeds will go to support Beaker Holum of Greater Washington programs. I always like to start these programs with a quick word on what it is that Beaker Holum of Greater Washington actually does and why I am the person who's often asking you for your support. We have many programs, and you can learn more about them if you might need help benefiting from them, or you want to volunteer by going to our website, which I'll put into the chat a little bit later. I like to just highlight a couple, and I want to highlight one today because we frequently get questions about it, and it's helpful. The more of you that are aware of it, the better it is for yourselves, but also to help your friends and your neighbors and anybody who might need to make use of it. And that is our hospital pantries. There are 5 of them in various hospitals in the greater Washington area, and they're available 24/7. There's a complete list of where they're located and how you can access them on our website. And that is under the services tab under Me'er La'olam. This is very, very important because people find themselves sometimes in the hospital and they're scrambling to look for where these rooms are. They're wonderful rooms. They have lots of food in them and all kinds of other religious amenities. They were very useful to people in Purim. And right now, Beaker Holum of Greater Washington is very, very busy getting ready for Pesach to support the many healthcare needs of people in our community and those traveling here for medical treatment. So the more you know about the availability of these rooms, the better it is. We hope that nobody will need them over Pesach, but we will be extremely prepared in the event that anybody does. So please familiarize yourselves where they are located so that if someone reaches out to you or you yourself could use them, they will be easily found. And God forbid, nobody should be in the hospital where there is such a room and not take advantage of it because they didn't know about it. So that's my spiel about our Beaker Holum of Greater Washington hospital rooms. And now I'd like to turn our attention to today's program. We are so fortunate to have really a tremendous halachic authority and an amazing presenter, Rabbi Dr. Shlomo Brody of Ematai, with us today. He'll tell us a little bit more about the organization that he's the executive director of. And the program and the topic that he's addressing today is a very important one, end-of-life care. And I know there'll be many questions. So Rabbi Brody is always wonderful about addressing those. Save it to the end of the program. You can also put some things in the chat if you want me to address them later. So save your questions, make note of them, put them in the chat. After the program concludes, after the presentation concludes, I know that Rabbi Dr. Brody will be so happy to address as many of them as possible. And now I would like to introduce Rabbi Shlomo Dr. Brody. Good morning.
Okay, Audrey, thank you so much for your kind words and introduction. And it's been wonderful collaborating with you and the Beagle Home of Greater Washington as we continue learning together. So today we're going to be really focusing a lot on the bread and butter of what Ematai does and deals with, and in particular, addressing the cases questions that come up in all sorts of forms when it comes to end of life care, and not always end of life care, but as people approach age or their healthcare journey takes different turns and approaches different crossroads. And as you can tell by the name of our organization, Ematai, we very much believe in upstreaming those conversations. Im lo achshav ematai, if not now, when? And part of what I'm going to try to do today is to familiarize people with some of the general issues that come up and to understand some of the general framework in which I think the issues get discussed within the community. I will be giving a little bit of a sense of a Matthias perspective on this, but beyond, I'll also, of course, try to cover as well the broader community, because it's not just I'm not trying to just preach what I believe in, but also make people familiar with the different ideas that come out there. For those of you interested in learning more about some of these resources, including some of our educational resources, so I put in the chat already a link to our consultation hotline or helpline. This is something that people reach out to us and they call us or WhatsApp us if they have some form of urgent question, or if they have some form of general consultation, they want to set up an appointment. We are available 24/7, actually. The reason why I stress the 7 is because, as Rav Mordechai Willig of Yeshiva University once said to me, 1/7 of the shilas that come up with in hospitals end of life care happen on Shabbos. So I said to Rav Willig, how do you know that? Right? And he says to me, because the angel of death works 24/7. And so the shilas come up 24/7 as well. And there's no doubt that's true. And so we try to make ourselves very available. But as I'm going to try to argue today, and many times really the problems emerge is when questions are only being asked in the midst of an acute crisis, in the midst of some form of incident in which people have to deal with it in the hospital and they have to make a call or decision sort of in a rush. And it's very, very important to upstream conversations in order to try to avoid some of these rush decisions that sometimes come up. And to make the conversation today a little more practical, I'm going to be drawing on some of the cases that have come up to our helpline, to the Ematai helpline. Of course, I'll be changing some details. It's a very small community. Everyone knows everyone somehow. And so if you think you know what I'm talking about, you don't, right? And I'm actually talking about someone else. But the truth is, as I'm sure you'll understand, that many people relate to some of the stories that I'll be telling. The other thing I want to mention is that when it comes to questions, I am more than happy to address individual personal questions, but those are really more appropriate for personal consultation, which, like I said, we're happy to set up. So when we get to the Q&A, I'd prefer not to address moms in this situation or my brothers in this situation right now, but more general types of questions and information that we'll get to. And I want to start with something that came up quite recently, actually, in a helpline. It was a case of a woman who was, I think, in her early 80s, maybe late 70s, and her daughter called me. And unfortunately, she had stage 4 cancer. It's terminal at this point. And the question came up is that something was bothering her. She was actually in hospice care at this point, and something was really bothering her, agitating her. And the question came up is if they should do some form of blood work in order to see if what was going on, and then to see what the next intervention may or may not be. And it was not going to be simple to do this blood work because of the state of the veins and whatnot. And but the family was having a little bit of a discussion, maybe a little bit of a disagreement even about the necessity of it. And the question came up with the hospice, I think, nurse in this case as well. And the question that came to me is, is this halachically obligated to do this test? And the premise was as follows. The daughter who called said, some of our family members have said, listen, Judaism believes in the sanctity of life, and not only the sanctity of life, but Judaism believes in living as long as possible and the infinite value of every moment of life. And therefore, if there's something that can be done to extend a person's life, it should be done. Okay? This is certainly a value and a belief which is out there. And I want to start off by addressing that issue in particular, because I think that in many ways, the dividing line in Jewish medical ethics when it comes to end of life care relates to this issue. Of course, there are many, many nuances as we go along, but there's a fundamental discussion, disagreement even certainly within the Orthodox world here, over this issue of, do we really believe that every moment of life is of infinite value? And I think the most articulate and outspoken advocate of this view was the chief rabbi of Great Britain, really in many ways one of the pioneers of Jewish medical ethics, Rabbi Lord Emanuel Jacobowitz. And Rabbi Jacobowitz was deeply involved in the political discussions in the British public sphere as well. He's an interesting figure in a lot of different ways. And Rabbi Jacobowitz writes the classic book called Jewish Medical Ethics. And then in 1983, has a nice little article, a little bit of overview. And he makes a couple of important statements here. He says as follows: in the matter of euthanasia, for instance, any deliberate act to hasten death, whether with or without the patient's consent, is incompatible with the Jewish understanding of the sanctity of life. Okay, that's absolutely correct. Euthanasia is something meaning the active deliberate taking of someone's life is against Jewish law. This is actually important for those of you in Washington, D.C. proper, because as you may know, there are 10 states as well as Washington, D.C., which have legalized physician-assisted suicide. And so that's important to know, to highlight this fact. This isn't our topic today. Audrey, maybe we should trigger that for some future conversation about the implications of it. But he's absolutely correct. I think this is universally held that such an act would be prohibited. But then he goes on to say as follows: Judaism regards every human life from the moment of birth as being of infinite value. Infinity, by definition, is indivisible, so that any fraction of life, whether 10 years or a minute, whether healthy, crippled, or even unconscious, remains equally infinite in value. All right, so here is a much stronger claim, which isn't just that the sanctity of life means we don't actively end someone's life, but it also translates into believing that every moment of life is of infinite value, even if that's of life when a person is unconscious. And then he goes on to say, that being the case, by attacking the ebbing of life of the terminal patient because it's deemed worthless, we'd rob all human beings of their absolute claim to life. Okay, and so here, this is a very strong claim, which is certainly out there. I'm not going to deny by any means that this is an idea that is out there. And I just think it's shared by, for example, by Rabbi Bleich Shlita of Yeshiva University in New York, Rav Aaron Soloveitchik Zatzal in Chicago, toyed around this idea in one form or another. Rabbi Eliezer Waldenberg, it says Eliezer Zatzal also had this idea in one form or another, which more or less asserts that every moment of life is of infinite value, and the proof being that if you would violate Shabbat in order to save even Chayisha, even any moment of life, that must show that every moment of life is of infinite value in Jewish thought. And that is certainly one school of thought. And this is where the question that was being sent to me was coming from. Listen, even if the person's in hospice care, we'll get to hospice a little bit later on, but even if the person's in hospice care, once they're in hospice care, we should still be trying to extend the person's life. And the question is this universally held? Is this actually a belief which is true? And without getting too deeply into it, in terms of the halachic sources and agadic sources that support this point, I think that there are many, many poskim who don't share this view, okay? And who understand that there's a notion in which Judaism recognizes pain and suffering is of great concern, to the point in which we'd say that someone's pain and suffering, or even the term might be used of quality of life, right? The term quality of life can be abused greatly, because you can say, oh, this person, we have some form of mental limitation or disability, that quality of life isn't worth. Okay, that's not what we're talking about. We're talking about quality of life, whereas a person has lost their functioning as they've aged or gotten ill, and includes the element of pain and suffering. And in those circumstances, halacha would say that we're not going to be trying to extend such a person's life artificially, because the important distinction here is that we believe in extending living, but not prolonging the dying process. And I think this view is well accepted by Rav Moshe Feinstein, Zatzal, Shlomo Zalman Auerbach, Zatzal, Rav Asher Weisshlita, current today. But I think actually one of the more interesting formulations of it came from Bnei Brak, from one of the great Dolim of the previous generation, the Steipler Gaon. And he writes this in 1975. Unfortunately, Rabbi Jacobovitz and others didn't have access to it because the letter doesn't get published until the year 2000. And the letter is actually written to a well-known doctor named Rabbi Dr. Abraham Twersky, right, who passed away a couple of years ago, a well-known figure. And the Steipler, writing from Bnei Brak, was addressing a question that Rabbi Twersky had. And the question was, well, is this idea true that whatever one can do to prolong a person's life, even only for chayisha, even only for moments, it should be done? And the Steipler says, I heard this idea in my youth, meaning I get it. This idea is out there. But I'm not really sure this is true, because as we're going to see in Yoredea, Siman Shin Lamed Tet, it is clearly stated that it is permissible for one to remove an impediment to a suffering person's death if this will prevent severe suffering, as long as one does not move or touch the dying person. We don't want to touch the dying person because we want to actively kill them, but you can remove impediments to a suffering person's death. And therefore, with regard to taking a passive stance, that is to say, with regard to withholding interventions, I don't think this is us, or in fact, it might be, as we're going to see, appropriate to do such a thing. And therefore, what the Steipler says is, I reject this idea of saying that we always prolong a person's life, because there are some times when not only it is a mutter to withhold intervention, you might actually be required to do so. And I think an interesting formulation of this idea is brought down in the beginning of the 20th century by the Aruch HaShulchan. The Aruch HaShulchan tells us that even when we see someone who's suffering greatly, v'tov lo hamava, he uses those words, it would be better for the person to die. Mikol makom, nonetheless, we cannot actively do something to hasten their death, because this is the realm of God. But he also includes, and this isn't our topic today, but he also includes and says that I do admit that there are times when it'll be appropriate to pray for mercy for the person, and our prayers should be that the person should die. Right. And one of those cases, those are cases in when the person has both feeling pain and they are terminally ill. In those cases, right, the Aruch HaShulchan says you should pray for the person, God have mercy, and they should die. And so this idea, we're not getting into the issue of prayer right now, but this idea of saying that on the one hand, we wouldn't actively cause someone to die, but we do recognize at times, tov lo hamavet, that a person might say, this is not a life that I want to live, is a halachic concept. I stress this point greatly because I really very much feel that there's a divide in the world of the way people think about end-of-life care issues and halacha on this issue. If you think that every moment of life is of infinite value, including when a person is unconscious, including when a person might be feeling pain or suffering, but nonetheless there's a great value to it, then your inclination is always going to be to do interventions that will extend a person's life. Or put it this way, to extend a situation where a person's heart continues to beat. Because after all, every moment of life is an infinite value. But if you recognize the notion of saying that there are times when a person has some form of pain of suffering, particularly when they are terminally ill, but not necessarily only, as we'll see, then you're going to be more open to the idea of saying there are times when we say it is inappropriate to do certain interventions, or we're going to say it's appropriate at certain points to say we're going to withhold continue new types of interventions or treatments. Friends, this is a huge dividing line. And so, if I go back to what I talked about last time, the importance of finding a rabbi to speak to on these issues and to determine who that person is going to be for you, one of those things you should ask them about is, just get a feel, right? What is their general approach on this issue? There are people who very much feel that, they want all interventions to be done as much as possible. They really believe in this, and that's fine. Okay. There's certainly very many, great rabbinic figures that have this approach, and you should find a rabbi who you see eye to eye with you on this issue. But if you're not of that viewpoint, this is not your worldview, then you should make sure that the rabbi who the questions are being asked to shares this general value, because otherwise, there's just going to be a disconnect on this issue in very profound ways. So just to connect even more explicitly back to what we spoke about last time, Rabbi Jacobitz was of the feeling that this whole idea of living wills, right, we talk about advanced healthcare directives, is just not really a Jewish concept, because he didn't agree to the whole concept of quality of life. He says the will of a Jew is to live. And he says, I believe in the Jewish view that there's no bearing on the value of life, which is absolute and infinite. In contrast, Rabbi Moshe David Tendler, following the teachings of his father-in-law, Moshe Feinstein, felt that this notion of quality of life is a Jewish concept, which is why he sort of developed, at least in the United States, the concept of a living will for the Rabbinical Council of America and other words. And to support this view, he quotes two very interesting stories, a Gadatot, one of which talks about a woman who goes to Rabbi Yosef and Chalafta and says, Rebbe, I got too old. And now, I no longer can enjoy taste of food or drinking, and I want to leave this world. And Rabbi Yosef ben Chalafta says back to her, not every moment of life is of infinite value. Stay strong, lady. But it says to her, what mitzvah do you have in your hands? And she says to him, well, I go to shul every morning. By the way, interesting source of talking about the zchuyot of women going to shul every morning in Chol as well. And so Rabbi Yosef ben Chalafta says to her, okay, well, if that's the case, don't go to shul for 3 days. And she doesn't go to shul for 3 days, and what happens? She gets her wish. She dies. And then the Gemara in Sota tells us this about the city of Luz, which is a city which the great conquerors of the world were never able to enter. Either Sancheriv or Nebuchadnezzar, and even the angel of death has no reshut to enter this city. But the Zakanim, when Datan Katsa Alan, when they get tired of this world, they would just leave the city and they would die. And so Rabbi Tendler learns from this that at times when we say that person is in severe pain, a person can say we're going to withhold further interventions. Of course, pain relief should be offered. And look at the final line. Judaism is concerned about the quality of life, about the mitigation of pain, and the cure of illness wherever possible. This is very important, friends. When a cure is possible, of course, we care about this, right? And we should try to push people, right? Even though it might be difficult sometimes, to do interventions which will ultimately be a bridge to a cure, at least to restore them to some form of healthy or what their previous health was. But if no cure or remission can be achieved, nature may be allowed to take its course. To prolong life is a mitzvah. To prolong dying is not. Okay? Very, very, very important distinction, right? And you see the two different worldviews, right? So this comes up all the time in one form or another, right? Where the attitude that people are going to take is going to be impacted based on this question. Now, having said that, there is a second part here that we have to always keep in mind, which is the following. Whether or not however you prioritize, if you acknowledge the concept of quality of life in halacha, or don't acknowledge the concept of quality of life in halacha, wherever it might be, you also have to deal with the fact that the reality is of medical uncertainty. The reality is sometimes that some things aren't possible, or some things not always clear, right? That certain intervention can be done, or if it is done, it will be helpful. So let's go back to the case I started off with about this blood test that they wanted to do. And, the instinct of the family members, of course, is, well, we should do this blood test. Now, when I spoke to the doctors involved, it was very clear that it wasn't so simple to do the blood work because of the condition of the patient's veins and whatnot. And it also wasn't clear that even if they did discover something, that there would be a helpful intervention to do, or if the intervention would actually cause more harm than good. Okay, this is a very, very, very important point, because whatever perspective you take on the earlier piece, right, it is always important to recognize the fact that we don't always know, right, if these interventions are actually going to be helpful or not helpful. And most healthcare interventions, particularly when people are more fragile states, come with side effects and they come with risks. And now, of course, I am not by any means discouraging people from sometimes taking risks to do interventions that can help them get better. I mean, that is part and parcel of why we believe in the sanctity of life, is that we want to push people. We have a lot to live for. We believe in having a lot to live for. And to a certain extent, there is a little bit of a cultural gap sometimes between, could be in the hospitals or the healthcare providers, or the general culture in which we live in, where, some people take the approach, listen, the person's over the age of 75, what's the point anymore? And I don't think that's a Jewish approach by any means. We've got a lot to live for, Baruch Hashem, particularly in our community. Many people have children and grandchildren and community members and a lot of support network. We've got a lot of things to live for, and we should be encouraging of exploring options, second opinions, options, interventions. And this is all a good thing and a positive thing, and stems from our will to live. Very, very important. We do believe in the sanctity of life, but we should always, always keep in mind that there are many times when some interventions just aren't going to help anymore. And I want to give an example going back to this earlier case. This family had elected for hospice care. Now, let's distinguish two different things. There's palliative care and there's hospice care. Palliative care means just the alleviation of pain, right? And it should be done at all stages of a person's healthcare journey when they are feeling some form of pain or suffering. There is no reason a person should be afraid by the term palliative care. It got connected to end of life care and to hospice because of the way it originated. It is a terrible, terrible phenomenon where many people suffer because they're afraid of the palliative care doctor. One of the members of Ematai's medical advisory board is a palliative care specialist. He does a lot of work with the Hasidic community in Brooklyn. And he tells me that when he goes to these homes, if they tell him Dr. Cohn, the palliative care doctor, is coming, the patient be like, keep him away. He's going to kill me. If they tell him Dr. Cohn's coming to give you chizuk, he's coming to give me chizuk. Oh, okay, sure. I'd love to have Dr. Cohn come and give me chizuk, right? And indeed, in some of the Pittsburgh, other places, many departments have now called their departments palliative and support care center, whatever it might be. Okay, so palliative care is a form of support care. Anyone in any stage of their healthcare journey who's feeling pain should be addressing this. Very, very, very important. Pain, by the way, kills. I don't mean that on a figurative level. I mean that also on a physiological level, and it's very important to address pain. But sometimes hospice is the option. And the reason why hospice is the option is because certain interventions are no longer going to be effective in extending life. At best, they will prolong dying. And in fact, many, many studies show that with certain types of illnesses, particularly cancer, but not only, when a person enters hospice type of care, which can also be done at home, by the way, they will live for just as long, if not longer, than having aggressive treatment in the hospitals. Why? Because the answer is that many times aggressive treatments in hospitals will keep people in hospital situations. They're going to be undergoing operations or other types of interventions that have side effects. And this causes people to die. And many times people live just as long in the hospice care setting and with much greater comfort. When I shared some of these studies with Rabbi Herschel Schechter Shlita of Yeshiva University, he started to cry. He's a very sensitive man in this respect. And he goes to me, Rabbi Brody, it's a mitzvah to publicize this fact. It's a mitzvah to publicize the fact that people can live just as long on hospice care as they can with aggressive interventions. So I said to Rav Schechter, I'm happy to spread it, but why is it a mitzvah to spread this? So he says to me, because I cannot tell you how many times I've seen people die with aggressive interventions in cold hospital rooms when they could have been much more comfortable in a much more meaningful setting in their house with their family around. And so it's a mitzvah to publicize this fact. Now, again, you don't always know, of course, because we live in a world of medical uncertainty. When is it time to say that we should be exploring hospice care, focusing on comfort, and when we should be continuing to try some form of aggressive intervention? We all know cases of family members or friends who, the doctors will say, I think I got 12 months to live. And they live 3 years, 4 years, whatever, longer, much longer. And we had one of my earlier consults when we started Ematai was a situation where someone had been told about 3 years earlier, you have 6 months to live. They went for a number of interventions. They, Baruch Hashem, kept them alive and fairly, I don't want to make it overly rosy a situation, right? But in fairly good conditions. And then about the last 4 or 5 months, it was clear, though, that the cancer had spread and he should have gone to hospice. And I sort of made a pitch to one of the kids involved, himself as a doctor, and he says, "Listen, we fought through this whole time. My parents aren't going to listen," and that was a mistake because he died, unfortunately, with a lot of pain and suffering, and it could have been a lot different. And it ended up being that they sort of went to hospice in the last 4 or 5 days. There's a woman who does a lot of hospice care in the frum community in Baltimore, not far from you, Chaya Lassen, and she likes to say to me, hospice is not Hatzalah. What she means by that is people call hospice too late. If you want to gain the benefits of hospice, you want to do this a little bit earlier on, right, in terms of making those decisions. Again, it's a judgment call, but it is certainly something which you should keep in mind, no matter what your view is of the quality of life, right, in terms of is every moment of life of infinite value. Because many times this will actually keep people alive for just as long, if not longer. And thank God now we have a very high publicized case of Jimmy Carter, which has highlighted this phenomenon, right, of how people can live for quite a long time in hospice care. Okay, so that is some major points to start off the conversation. Now, once we remember, the Stipler said he wanted to quote the Gemara in Yoreh De'ah, and this comes up all the time, and this is a very, very, very important distinction. It is a complex distinction in halacha. I'm not going to get into this right now in terms of where this comes from, but in general, within halacha, you can see this in Yoreh De'ah here. You see this in the Shulchan Aruch. We have a discussion of a person who is a goses. A person who's a goses is in the dying process, and it is forbidden to cause a dying person to die quickly. Okay, so this has a number of different ramifications. So, for example, you would not move that person, right? There's some sort of active causing of that person, or something removing it underneath him. That's an active thing that might hasten their death. However, if there is something which is preventing the soul from departing, okay, and again, what this is, that is allowed to be removed, right, from the situation. And this is because that those impediments are not considered to be an affirmative act that you're causing someone to die, but you're just removing the impediment, misir monea. The example that they give here, which obviously is very complicated, is you have a wood chopper, and the wood chopper is causing noises outside, and this is causing the person to not be able to pass away. You're allowed to stop the wood chopper from chopping the wood and allow the person to die peacefully. Okay. Now, again, how you apply this to contemporary medical interventions, ventilators, pressors, dialysis, and whatnot, is obviously more complex than we can get into today. But the important point that emerges, which is super important, is to understand that withholding, not starting or not continuing, right? We'll get into exactly what this means, but withholding interventions when you have a situation where the person has deemed it to no longer be of value, we'll get into what this might be in terms of continuing living, particularly because of pain and suffering, is permissible. So let's give a couple of examples of this point. We'll see some exceptions, of course, as we go along. So if Shlomo Zalman Auerbach dealt with the following case of a person who was in pain and suffering, and they wanted, he had, I think, gone blind from diabetes, and they'd amputated one leg, and they're now going to amputate a second leg. And the person said, I don't want this anymore. Just, this is enough. And Rav Shlomo Zalman said, the person is suffering, right? He thinks, we'll get into this a little bit more. You have to provide food and oxygen, even if he doesn't want that. But any other form of medical intervention, you can say to the person, listen, you don't have to do this. And while Shlomo Zalman in Yerushalayim says this, I think the posek that is strongest on this point is Rav Moshe Feinstein. Rav Moshe, in a number of his tshuvot, talks about this idea and says that at some point it is appropriate to say we would withhold interventions. And he discusses a very, very common case, comes up all the time. We have this a lot, where let's say someone is in pain and they're terminally ill or certainly quite ill, acutely ill, and they develop a second illness, classic case, pneumonia, right? So would a person have to provide antibiotics in order to deal with that second illness? Right? Even though all treating the pneumonia is going to do is bring them back to the situation where they're living or dying with the first illness that they have. And Rav Moshe's position is that the patient can have a choice in this situation. Right? There is a certain amount of autonomy, and the patient can have a choice to say that in such a situation, I want to withhold, right, new types of interventions. Right? Comes up all the time, friends, all the time, these situations where someone's got a lot going on. It could be that they're terminally ill, or it could be they just have a number of different factors. We don't always know, of course, what those factors are that are causing a lot of ailments, acute ailments, and we don't seem to have any form of intervention that can restore, let alone cure, but at least restore some form of health. And Rav Moshe's opinion is that withholding interventions in this case is an option. Now, I stress option. If the patient, family member, right, wants to continue to do this, right, because they think it's maybe a bridge to somewhere, or because they're willing to live with the pain and suffering they have, or they have a bar mitzvah coming up, whatever it might be, right, that's an option. But the patient has an option to withhold certain types of interventions. Now, Rav Moshe stresses that in his view, and we'll get this a little bit later on, but in his view, oxygen and nutrition have to be provided because he's always under the assumption that not providing oxygen or nutrition will be bad and painful for the patient. Okay, so let's talk about nutrition for a minute. So this is a well-respected idea that artificial nutrition and hydration should always be provided. But it's important to recognize that this is a lot more complex. And Rav Moshe, remember, dies in 86, right? So there's a lot of research that's happened in the last 30, 40 years, right, in which we know about the benefits and not such great benefits of artificial nutrition and hydration. I'm going to pull up here for a minute, by the way. Just give me 1 second. I'm going to put in the chat as well, Ematai section about artificial nutrition and feeding. There's a lot of important details in every case, right? So everyone's got to know, right, their circumstances, and you have to obviously case by case. But we have also here a video which explains the different types of artificial feeding and the different ways that this can happen, IV and subcutaneous and a PEG. And you don't know these means, that's fine, right? But it's important to familiarize yourself with some of these things. And the reason is that while it might be generally true that artificial nutrition and hydration is of benefit, there are times when it is simply not possible. Okay, is times when the body will simply no longer take some forms of nutrition and hydration, particularly when it's done by an IV, but not only. And so what can end up happening is people will say, we got to give, mom, get an IV going. And the doctors will say, we don't have a way of doing this right now, right? Because the body won't handle this. So it's actually overload the body. And Rav Moshe is actually pretty explicit that if it is medically counterindicated, right, in terms of medical artificial nutrition and hydration, if it's medically counterindicated, right, then it's not a type of medical intervention that will be allowed, right, because it's just going to cause harm and discomfort. And it can lead to choking, it can lead to infections, blood clots, right? There are many different types of situations in which it's just medically not going to be possible. Another important thing to note, and Rav Moshe states this as well as many others, there are times when a patient might say that I don't want this type of artificial nutrition hydration. This is a super sensitive situation because it could be the patient saying that because of their discomfort and a lot of different reasons. And so you want to talk them through. But in the old days, and not so old days for that matter, there'd be times when we would force feed a person, right? Even times when we would like sort of, hold down their wrist and tie their wrist or whatever it might be in order to provide artificial nutrition and hydration. And Rav Moshe and others are emphatic that we should not do this. We should not force, right, in terms of like physically compel a person in this way. Again, this is within the world that recognizes that, right, we don't think of every moment as of infinite value. If you think every moment is of infinite value, right, you're going to try to even might force a person to eat, but it's also not a very effective way of doing it because a lot of times when you force people to try to eat, they'll pull out the all sorts of interventions. It's not usually a very successful way of doing things. I see Audrey, you're nodding from different experiences, as we all know. So this is important to know that sometimes it's just simply medically counterindicated. And sometimes the reason why patients don't want it is because they don't actually feel hunger. They don't actually feel it. Their body's sort of shutting down in this way. It's obviously fragile situation because sometimes they just need some help. And many times what's most effective is ice chips or some form of other applesauce or different types of things involved that will help the person bridge this medical episode. So particularly cases, we just had this case in the southern United States where someone was in a very difficult time eating and they're discussing different medical interventions. And it was a case where it was really a bridge, right? They had to give artificial nutrition and hydration here, but it was a bridge that ended up being able to be stopped because they were able to start and recover their ability to swallow again. Okay, that's great. I mean, that's amazing, right? And they're back home now. I'm not saying everything's rosy-dosy, right? Everything's perfect in their health, but they're back home and they're interacting with their family in meaningful ways, and their pain is under control, and that's wonderful. So it's always a sensitive balance, but it's important for families to keep in mind, particularly that sometimes, particularly as people approaching death, the body simply isn't interested in taking in that type of food. And you might then have to be thinking about in terms of ice chips and other types of things to provide some form of nutrition and hydration. Okay, so that's a very, very important point to note that Rav Moshe stresses here. Now, the premise of which we mentioned beforehand is that withholding interventions is acceptable, but withdrawing interventions that will cause a person to die is a problematic. The classic case which comes up has to do with artificial respiration with a ventilator. in which Rav Moshe says the following. He says, listen, wait for the oxygen tanks to run out, and then you can test to see if this is helping or not. Rav Moshe is referring to a reality in which ventilators were being hooked onto oxygen tanks. After 5-6 hours, the tanks would run out, and then you can make a decision whether you just keep the oxygen going on another tank. Today, in artificial ventilation, happens with a continuous line through the wall, right? Central type of supply of oxygen. And except in cases when people have to be transported, when they're hooked onto an oxygen tank, there's no stopping of the ventilator. And this is what causes the major discussions, which comes up where in the general Western world, they will allow for the withdrawing of the ventilator, which many times, not always, but many times will lead to a patient passing away soon afterwards. Okay, it's not always instantaneous, by the way, and it's actually quite important. But for assuming right now, especially when a patient is what's known as vent dependent on the ventilator in great levels, if you quote unquote pull the plug, right? If you do palliative extubation, if you remove the ventilator, this will hasten and cause the person to die. The vast majority of poskim do not allow this. Okay? It gets complicated. There are a lot of nuances here, but they do not allow this. So for that reason, there are a couple of implications. Implication number one is something that Rav Asher Weiss Yerushalayim always emphasizes. And he says the following: do not intubate if you think that there's going to be no hope to extubate. Meaning, if you think that intubation is a bridge to nowhere, it is not going to be able to remove to someone, well, what are you doing this for? Right? It would be better than to withhold putting on that continuous form of life support if it's not getting you anywhere. Okay. Now, of course, however, there are times when doctors will say, listen, it could be that intubating this person is going to be a bridge to getting them through this health episode, and then we'll be able to extubate them. They'll be able to breathe again on their own, right? And then we want to do this. And sometimes people just don't know, right? And doctors are not prophets. They're wonderful, wonderful people, but they're not prophets. And people get very angry at doctors for not being prophets, but they're not, right? And so it's important that doctors will say, listen, I think this might be worthwhile to do, but I'm not sure. Sometimes they'll say, listen, there's no point to doing this, right? It's just this intubation is not going to help. If the intubation is not going to go anywhere, and all this intubation then is going to lead to is a trach being put in, right, in terms of into the throat, right, in terms of some form of support, and this isn't going anywhere, you do not required to insert, right, to intubate the person. However, if you think there is a hope, right, that this could be a bridge, an intervention that will help the person, then there is good reason to intubate. But then people get afraid. What do they get afraid of? They're saying if it doesn't work out, we're going to get stuck. So here's what I want to explain to people, right? No one should be afraid of getting stuck. If you think this is an intervention which can bring the patient back to some form of baseline health, which they'll find meaningful, if you think there's hope that when the intubation will lead to extubation, they'll be able to remove it, then this is a worthwhile intervention. This is something Rav Willig, Rav Schechter stress greatly. And if they get, so to speak, quote unquote, stuck, we will figure out how to extract the situation. How do we do that? The answer is very important. It is problematic, according to the mainstream approach, to stop continuous interventions. A continuous intervention is something which is going 24/7. But many types of interventions are the types which are cyclical or intermittent. What I mean by that is they stop. Okay, so for example, you might say, let's start surgery or radiation. Let's see if this, going somewhere. And then you realize, okay, stop. Or dialysis. You don't do dialysis, with the exception of a few cases in ICUs, but you don't usually do dialysis 24/7. It's not continuous. And so in between dialysis cycles, if you realize this isn't helping anywhere, this is going to help, whether it's radiation, it could be many other things, then you stop. You don't start again. That is considered to be withholding and not withdrawing. That can be true with chemo. That's many forms of antibiotics and IVs, many other things that are bags, so to speak, right? Which will run out. Right? This is a well-respected position, not only of Rav Willig and Rav Shechter, but of major poskim in Israel. This is why Israel's terminally ill law allows for this. In Israel, it is forbidden under Israeli law to remove the ventilator if you think it's going to lead to death. So what do, right? Do everyone in Israel get stuck? No, the answer is for many, many people, they have other types of interventions that are going on, which are cyclical or intermittent. So it could be dialysis, it could be vasopressors, right? Blood pressure, right? It could be other things which will stop, and then you don't have to start it again. That is considered to be withholding and not withdrawing. Rav Willig and Rav Shechter like to say that we should publicize this because it's a life-saving psak. Why is it a life-saving psak? Because many times people will say, I'm not going to intubate because I'm afraid that they'll get stuck. And Rav Willig say, now, again, if you think doctors are saying there's no point to intubating here, don't intubate. But if you think there's a chance, right, that this is going to lead to something, it's going to bridge to somewhere, then do it. And if we get a situation where the intubation isn't, not going to be extubated, well, in vast majority of times, there are other types of interventions that can be stopped. So I had a really fascinating case to the helpline a couple of weeks ago. A woman calls me up. She more or less says to me, I'm firmer than you. Yeah, which I actually wasn't insulted by, right? But she looks at me and the thing, she sees I don't have a beer, okay, whatever this and that. But it wasn't a secret to her that I didn't have a beer. She's on the website, but she was very friendly and said to me, she's trying to place herself in the oilama where she is. And she tells me, I want to, we're having this discussion with the doctors, this or that. And I want to know if we do a certain intervention, they're gonna have to intubate. And if it doesn't work out, can you find a way for us to get off of this? And it was very, very interesting. And she called me because she knows of the poskim that I work with, and the poskim that she works with wouldn't have necessarily allowed this, and because they believe in every moment of life is of infinite value. But she knows the poskim I work with will try to find a way to extract it. Now that raises a lot of issues for me, right? Because I want people to genuinely come and ask shilas and not just be shopping, so to speak, for shitot. But it was a very clear case where it highlighted the fact that this position allows for people to sometimes take interventions when they think there's a chance that it will succeed. And if it doesn't, we will prevent a person from getting stuck. So about 2 months ago, I got a call. I'm not getting into all the details. A woman is graduated hospice because she's been on hospice for 6 years. That's right. Hospice be for 6 months. She's been in hospice for 6 years. And the hospice has basically told her child, who's in her early 70s, right? The child is in the early 70s. Okay, so imagine the parent is, right? And saying, listen, we just can't keep him on hospice anymore. And they have a certain types of interventions that are clearly intermittent, which has been keeping them alive in hospice. And so I speak to the daughter, I speak to a couple of doctors on our Ematai's medical advisory board, and the woman sort of says to me, listen, we tried to do this to help mom. It didn't work out. And now she's been sort of stuck for 10 years, 6 of them which in a hospice, a really bad state. And so I called one of the poskim. I came up with a plan, but I wanted it to be in the shore. So I called one of the poskim I work with. And the first thing he goes, why did they call 10 years ago? We could have helped 10 years ago. Right. And so I'm stressing this story not to make the woman feel bad, of course, but to stress the point that we can help. We can help people deal with some of these types of issues, which are super, super sensitive, and try to balance on the one hand, yes, sanctity of life. We should try to live. We should try to live meaningfully. We have a lot to live for. We believe in the sanctity of life. But we should also understand that Judaism recognizes the value of quality of life. And there are times in which we say we are going to withhold interventions and withhold them in ways in which even if we started something, but they're cyclical or intermittent, we won't continue or restart them. And this is a very important attempt to balance different types of values. And it's very, very valuable. We had a case a couple of months ago, and this relates to the final issue that I want to get to, and then I'll open up for questions. And this has to do with a very sensitive area of dementia. Dementia is a very, very sensitive area, and it affects many, 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 many people in different forms. And it was a case where the family member had dementia. He was in the 80s, and his sister calls me. His sister been doing a lot of the care for him. And, the question became about whether or not this was at this certain point going to give them some form of artificial nutrition or hydration and what's known as a PEG tube. I won't get into the details, but it's basically inserting directly into the stomach food, so that way avoids the whole esophagus area because they couldn't eat anymore this way. Largely to their dementia, but as in many cases, people get older and dementia, there are other comorbidities, other factors as well. And here you do have a great divide in the world, even of the world of the poskim, which I'm working within, who care very much about quality of life, where some believe that dementia is not a form of pain. Dementia it's not a pleasant situation by any means. It's very difficult for the family, but in of itself is not a form of pain. And therefore, we should be doing artificial nutrition, hydration, other interventions to keep people alive and living, even when they're going to be continue to be in a state of advanced dementia. For example, Rabbi Professor Steinberg, so a member of our medical advisory board, one of the chief bioethicists in Israel, is very strongly feels this to be the case. And Rabbi Willick and Rabbi Schechter in Yeshiva University feel that that is actually a form of suffering and a form in which we'd say we would withhold interventions. Now, what happened in the case in which frequently comes up is that it wasn't just dementia that was going on, right? In this patient, there are other factors that are going on, but because the patient couldn't communicate cognitively anymore with us, it was very hard to figure out what was causing that form of pain and suffering. And literally an hour ago, I was just talking to a new member of Ematai's medical advisory board who specializes in dementia. And she said to me, listen, every case is going to be different. In every situation, some people can seem very peaceful and calm and even advanced states of dementia, and other people can be in pain and suffering, and they just can't communicate it. And of course, every case has to be different. So in that particular case, the family had done a lot to keep their loved one alive for quite a long time, even after doctors had told them already they weren't sure this was going to be helpful. And they got to the point, though, where they came to me and said, we don't want to do this anymore because we think now we're pretty convinced that she's actually in pain. Right? They were very convinced of the pain. And they had started a number of interventions. And without getting to all the details, I looked at their interventions they had done. Many of them were cyclical and intermittent. I spoke to the doctor and said, okay, when these cyclical intermittent interventions stop, we're going to not restart them. And that's what happened. And of course, we made sure there was pain and comfort care. And she passed away 3-4 days later. Now, I cite this story because it's a good example of a family that cared very much in the sanctity of life, that very much wanted to keep their loved one going as long as they could. But when they got to the point when they saw that she was suffering, and it could be that they should have realized that probably a couple months earlier, frankly, but like I said beforehand, a lot of times that's a judgment call. It's not always easy to see, not just on an emotional level, but even on a scientific or medical level. We were able to help them deal with that situation. And so, I think that I want to end with a final thought. There's a balance of values here. There's a balance of values that we truly believe in the sanctity of life, but we also recognize notions of quality of life. There's a balance of values in the sense that we understand that there's medical uncertainty, right? And so this is not always so simple, right? To understand, you have to make judgment calls, right? We understand that and this is an important point to stress, we want to extend living, but we don't want to prolong dying. And of course, that's a nice, right, catchphrase. It's not always easy to implement in practice, but it's something which is very important I believe, to keep in mind in terms of our approach. And once you have that approach, you recognize that there are times when we're going to respect patient choice. And that's why this is very important. And the last thing I want to say is that it is super. Oh, I put this here. You can see here a little bit. One second. Um, some of the values I'm mentioning here, we have in Ematai's general principles of end-of-life care. And the last thing I want to say, which is super important, is in the firm community, there's a lot of tension at times with the healthcare providers about what interventions should or shouldn't be done. Okay, now sometimes this is coming because of hospital administration policies and money and cost and whatnot. But many times this is simply a perceived um, gap in values in terms of, do we share all the same values or not? And I think it is super, super important to try to establish a healthy and open conversation and relationship with your healthcare providers to make sure that you're getting the culturally sensitive care that you want, but that everyone should be frank and honest, right? And to explain, right, what these issues and understand. And many times, people say the doctors, they don't care anymore. They don't, they're trying to kill my mom. Okay, so the first thing I sometimes say to them, are you talking about the same doctor who in 2020, who didn't have proper protective equipment, was taking care of you when you had COVID and risking their life to save you? Is that the one that's trying to kill you right now? I try to make the point, right? Let's be careful what we're saying about the doctors. But beyond that, a lot of times what's really happening is that, of course, this is emotionally difficult and this is sensitive and there's a lot of issues at play, but it is super important to create a healthy and open conversation and discourse with your healthcare providers to make sure that they understand your values and your goals and your preferences and to try to work out, right, what's best. And I believe the halacha gives us a very, very good framework for thinking about these issues and a very sensitive framework to think about these issues. And which is why I always tell people you should feel free to contact the rabbis and others in your community who can help you with this, because not talking about it is really not healthy. It's not healthy because you can make mistakes in different directions, and it's also not healthy because you can use a support network. And I know Bikur Cholam does a lot of great work on the support element as well, and I'm sure there are local rabbis, and of course, Ematai is always available for consultation whenever we can. And as we say, Im lo achshav Ematai. I'm sure there are people on this webinar, on this conversation who are dealing with one form or another. And it is always good to have conversations with your physicians, with your family members, with your rabbis on these issues. Audrey, I think we'll turn to some questions. Maybe you want to
Yes,
MC or take control here.
sure. My pleasure. Well, first of all, thank you for that extremely clear and compassionate um, presentation. There were a couple of questions in the chat, so I'll just bring those up first, and then I think we can open it up and people can unmute and ask directly if they choose to. You can also, if you prefer to put questions in the chat, you can feel free to continue doing that as well. So one question that came up earlier in your presentation was, what about if hospice gives a lot of morphine? I think what the person is referring to is that they're giving the morphine to ensure that the person is pain-free. But I guess the side effect of that could be hastening death. So is that halachically acceptable?
Great question. One of the classic questions that comes up. Intent here is critical. So morphine or the types of pain medications are really crucial. You do not want to, for yourself, for others, and there's no need for people to be dying with pain and suffering, unless, of course, they feel they can tolerate it and they want to because they want to be more alert or whatnot. Unfortunately, pain medication sometimes is a trade-off with alertness. But many times we absolutely must give people different forms of pain medications. And there could be times when it's perceived that there's a need for greater dose in order to alleviate the person's pain. We just had this. I mean, this happens all the time, but we just had this a couple of weeks ago where a person called me up. It was probably about 11 o'clock at night. And the hospice doctor said they perceived a lot of painful breathing, like heavy breathing. They wanted to increase the morphine. And the family members said, but we know that sometimes if you increase the morphine, it will depress breathing and then hasten the person's death. So a couple of things to know. First of all, well-trained and experienced, and many people are in this category, palliative care specialists, hospice doctors, nurses, whatnot, will know how to increase it in very small amounts to make sure that they alleviate the pain without increasing, speeding up, hastening. Meaning this belief that if you increase the dose, it always increases, it speeds up or hastens someone's death isn't true. Sometimes people die because they're just nearing death. And what you've done, of course, is alleviate pain, right? So it's not always true that increasing the dose will cause hasten someone's death. But even if it does end up being the case, or would be the case, when the intent is to alleviate pain, and when the effect is not definitive, right? It's not for sure it's going to speed in the pain, speed in the death, excuse me. Then it is certainly halachically permissible and to provide and increase the dose as necessary. And this is l'kol hadeos, right, in Hebrew and English, depending how you want to think about this, right? Everyone agrees, whether you're a part of the camp that says that every moment of life is infinite value or not, everyone agrees you got to deal with the pain, right? It's not something, and so, this happened, just like I said, a couple weeks ago. So they called me up, and then it was a very low dose they were on at the time, and they want to increase a little bit. And I said, absolutely fine. And one of the children said, isn't this going to cause them to die? And I said, A, this is a small amount. They're increasing it just a small increments. And B, you don't want your loved one to be in a state of pain, right? So that's always the value. And I think when, you just express this to hospice care, they understand this. People get this. This is not like a new thing. We're not the only ones that feel this way. It's not just Jews, not just religious people, right? People will get that. And the hospice will understand it. Now, I see in the question, though, that one of the questions that comes up is of not providing nutrients, okay, hydration and nutrients. So here it gets a little bit trickier, okay? Here it gets a little bit complicated because I mentioned earlier that it's certainly a widespread position that hydration and nutrition need to be provided. So when electing and choosing a hospice provider, that's certainly one of the things that you want to bring up is, will this be an option? But again, it's important to keep in mind, many times people, as they near death, which is the case when people are in hospice, the body cannot handle or will not take in some form of artificial nutrition or hydration. And many times also, what it'll only take is basic water or salt or something along these lines, and not full nutrition. Now what's known as DPN. And so, we have to be careful when people say, oh, the hospice isn't willing to provide food. Well, let's figure out what exactly they're willing to provide, not willing to provide. Right. And so, it's important to always keep that in mind. I don't want to answer, should intravenous nutrients be provided? Well, it depends a lot. It really depends. And there's a difference between nutrition and hydration, and each case needs to be governed on its own.
Thank you. I see that Dr. Nancy Weissman has her hands up. So Nancy, did you want to unmute and ask a question? No. No, can you hear me? Nancy, did you want to unmute and ask a question? Okay. Well, while we're waiting for her, maybe,
Yes.
oh, you are?
You got
Okay,
me?
great.
Great.
Sure.
Oh, no. Hi, thank you so much for your presentation. I've been studying this for a while myself. You said that one of the really important distinctions is between prolonging living and prolonging dying. What is the definition? How do you distinguish?
Yeah. So listen, it's not something that I'm going to be able to quantify in terms of this. And I think there's no doubt that people are going to have a little different views on it. One of the ways of thinking about this is as follows. We very much want to prolong living when people can have meaningful interaction with the world, with God, with their family members, right? That they can do this in a meaningful way. I don't now, just because it's meaningful doesn't mean that it doesn't involve pain and suffering. There are many people that have discomfort, let alone pain and suffering, but feel that they are meaningfully being in this world and interacting, doing mitzvot, and interacting with their family members, and it's very, very beautiful. And that is something which, especially when a person says that they can handle this, is something which I think we should not only respect, but encourage and try to give them strength to do this. So sometimes it's not just about the doctors, of course, or the nurses. It's also about the family support or the community support that's going to make that possible for people. One of the
So in other
reasons that
words, go ahead. I'm sorry.
no, I'm saying one of the reasons why in close-knit communities like the Jewish community, and many times that we can meaningfully extend people's living is because we have good support networks. And so in those cases, I think that's
Sorry.
very important. We can extend. But when people are saying either they cannot have meaningful interaction with the world because of their health condition, right? Whether it's advanced or whatever it might be, or that this is involving pain and suffering, which they feel is no longer tolerable, that's not a situation which I want to extend.
Okay, so dying is not a medical condition. You said it depends on the support. It's not a medical condition.
Correct,
you can't
right?
know if somebody's dying or living, medically speaking.
Correct. I agree with that. But I think that that's why I'm introducing some subjective factors to this as well, which is why that those who don't believe in quality of life, who believe that every moment of life is infinite value, aren't going to talk with that slogan. Their slogan is going to be every moment of life is of infinite value.
Okay, so what I'm going to say, it's our problem period. Let's not set up straw dogs. Even people who say that every moment of life is of infinite value aren't going to torture someone.
Yeah.
There's often comes a time where it's pretty clear. I knew a situation where someone with dementia, there was a question, sepsis, and was there an abscess in the liver? And the only way to find out was to get an MRI, which would not have been possible because with the dementia, they couldn't do the sedation. They would have to sedate in order for him to be still. In order to sedate, he would lose, so much ground. So they tried a different antibiotic to see if it resolved, it resolved, and if it didn't, it didn't. I think we have to be very careful not to make it us and them. I think it's one of the.
So I agree with that, Dr. Weissman. I agree with that. And I think that story highlights a couple of things. First of all, is even if you think that every moment of life is of infinite value, recognize that sometimes continued intervention is just medically counterindicated. It's just not going to work, right? Isn't what we can do. And everyone agrees
medically
that
speaking, you don't do it. It's harmful.
Right.
It has to balance on the side of helping. And again, you're right, you don't always know. But I think more often than not, that decides it for you.
So many times that will decide it. And that'll be just the issue, right? Nerds, there are just some times when, unfortunately, death is a reality, and you can't do anything about it.
You can't do anything about it. This is what's going on. In order to try to help him, we would hurt him. That doesn't make any sense.
Right.
So
that's right.
That's right. So what I worry about is this. When we get into the subjective, there's so much wiggle room, and we open ourselves to some pernicious philosophies.
Yeah.
So, call kavod to you and to this. I'm happy to talk to you privately. I don't want to take up your time.
No, but I want to address the point which you're making, which I agree with. I agree. Once you enter the subjective zone, right, you can sometimes get into situations where people stop doing interventions when, they're probably appropriate to do interventions. I'll tell you a story. A person called me up on their helpline and said, my dad has a certain condition, and he promised me if they told me to do certain intervention, don't let them do it. Now the doctors are suggesting to do it, and he's going along with it. So the son calls me up and says, should I tell my dad not to do it? Because I promised him not to do it. I said to him, absolutely not. Your dad's going to be out of the hospital in 2 days, right? He's going to be home. And he thought this situation would look like this. It ended up looking like something else, and now he's very happy to have it done and go home and spend time with his grandchildren. So there is a very strong danger, right, in entering too much of the autonomy and entering some of the element. But it goes both ways, because there are also times when people do types of interventions which just make no sense and just cause pain and suffering. And so
Yes.
we live in trying to balance a very difficult medical world and cultural environment that we live in. And that's going to be the balance that we're going to have. And Gesher Tzar Ma'od, as the Menachem Breslov like to say, right? This is a very narrow bridge that we have to deal with. So I appreciate the comment. Audrey, who's
Uh,
next?
We have a couple more in the chat. Thank you, Nancy. So one person is asking, do you happen to know what the position of the Lubavitcher Rebbe Chabad was on, I guess, these issues of
So,
extending
okay,
moments of life versus the other?
yeah, so I'd say that within the world of Chabad, on every issue, I've actually discovered is that there are many different opinions about what the Rebbe said and what Lubavitch says and whatnot. This is so we work with the Chabad community a lot. Actually, in your area, right, we have Rabbi Dr. Avi Rosenberg, was a pathologist at Hopkins, is very involved and
Yes.
one of the major Chabad poskim is actually in Sydney, Australia. Diane Ullman, who is both of them are members of the Medical Advisory Board and work with them a lot. And in the Chabad world, though, there are different opinions about different things, and some of their disputes are also what did the Rebbe feel about certain issues. The same way in certain circles, the people dispute what Moshe Feinstein said and dispute what Soloveitchik said and whatnot. So I can't. I also think that the Babich Rebbe sent a lot of people to Moshe Feinstein on these shilas. I happen to have seen a number of stories like that. So I don't know. I can't say more than that. But in the world of Chabad, there are different opinions, like in the rest of Orthodoxy.
Right. Here, there's a sensitive question here. I don't know if you have time to address this now or even conceptually, but there's a person who's saying they work often in the space of children and teenage patients, and they've come across something called terminal anorexia nervosa, where healthcare providers will suggest that there's nothing more to be done for a teenage patient with severe anorexia, and they're placed on hospice because they can no longer be helped. And she wants to know if you've ever heard of such a concept, and if so, I guess what have you what are
Yeah,
your thoughts about it?
yeah. Well, listen, like everything, each case to their own, right? For sure. But this became a big issue a couple of months ago, an issue for a while. A couple months ago, the New York Times had a big article on this, if I'm not mistaken, and that raised awareness of it. Um, we're entering the area of mental health here as well, and I think it's very, very dangerous to group mental health with other types of health impairments and illnesses. I'm not saying that's not possible that you might have such a situation like this, but I know there are many who are fearful that we're rushing a little bit to saying that they can no longer be helped. Again, like with many issues of mental health, this is an area which needs further development. But I take each case on its own, but I really don't want to be rushing to saying they can no longer be helped. I think that, again, not minimizing the seriousness of the situation. These are real medical issues here. But I am nervous about, particularly when you have younger people, and it's a combination of both youth and mental health. It gets me quite nervous about making such a declaration.
Yeah, I understand. And I understand there are also poskim that specialize with mental health concerns and halacha as well. I'm
Yeah,
sure
absolutely.
there's a combination, a team approach might be.
Absolutely. There's always going to be a team approach in those issues. And yes, you're going to have to case by case here.
Yeah. Okay. First, I want to ask, is there anybody else who would like to raise their hands, unmute, and ask a question?
I see there's a question in the chat here about
Yeah.
some severe connective tissue disease multiple surgeries, TPN, always in pain with no energy, wants to go on hospice, but this means stopping nutrition. How do we deal with this halachically? So again, case by case, but yes, if a person is going to be having multiple health interventions and it is not getting them anywhere where they're going to remove their pain and they have no energy, it is not clear that they're actually going to live longer with these interventions than they will on hospice care. Now, the issue of stopping nutrition, though, becomes an issue. But, one of the things that we're working on a lot is to trying to make sure that in each area of major Jewish communities, that you have certain hospice providers that you feel can make sure that they're doing it in a culturally sensitive way. So, that's something, an issue project that we're actually working on right now, because there are many times when hospice just is the right way to go. But I just, I want to stress this point, having the person continue to go through these interventions and they're not helping them here, is not necessarily a big mitzvah to do to someone. But again, case by case on these issues.
Thank you. I want to conclude with a note that I just got from somebody offline who's had joined us for the presentation that I think kind of sums up why we're so grateful to you. I want to thank you for this presentation. My parent is currently in hospice at home. I feel so much better about it after listening to this presentation. So many of my concerns were addressed. I don't think we could say thank you in a stronger way than that. And so I'd like to, again, express our appreciation, our hakarat hatov, to Rabbi Dr. Brody for as I said, a very clear, I see some applause. They have Ematai is a wonderful website. I know it was put in the chat before. You can easily find it as well with so much more information. There was somebody who asked in the chat if it would be possible afterwards for you to make your sources available. I don't know if they're already available on your site or if that's something you could send it out that I could send to everybody or to
I think we have this whole thing besides being recorded here. I think it's also on our website as well already.
Perfect. Okay, I thought so. Just like I said, it's such a rich website with so much wonderful information. You can learn a lot by visiting there. So once again, thank you.
And Audrey, if I can just say thank you back to you for facilitating this and for Bikur Cholim. And also to say, people, I really want to stress the thing I end with. Don't feel embarrassed or ashamed to ask questions and seek help. It's so important on the halachic level, but well beyond the halachic level, on emotional level, on so many ways. Don't go through this by yourself. There's no need for it, and you'll feel much more comfort and support by doing it with others.
So well said. I think you'll also find when you do reach out for help that you're not alone, that people have been here where you're standing, and that you'll be able to help somebody else because other people will be where you're standing. This is everything Rabbi Brody has spoken about in this presentation and his previous ones is something that we all at one point or another confront. So again, thank you all for coming and making time on your Sunday. And thank you, Rabbi Dr. Brody, Ematai, the wonderful collaboration, and perhaps there'll be more to stay TBD. All right, everybody, enjoy the rest of your day. Thank you.
Yasher Koach, Rabbi.
And thank you. I always forget to thank Menachem Hamburger, and I apologize for that. It's because you're so humble. But really, this presentation would not have happened without board member Menachem Hamburger interest and navigating and connections. So appreciate that. And also Rachel Secunda, who works with Ematai and has been so helpful making flyers and making sure that these presentations go off smoothly without a hitch, which is no simple feat. So thank you, everyone. Yasher Koach, and have a wonderful day.
Thank you.
Thank you.
Thank you, Rabbi.